A little bit and get settled. All right. Well, I think I'm going to go ahead and get us kicked off. I know we've got an excellent panel and I don't want to waste any time here. So thank you for joining. My name is Tammy Jo Hill and I am a senior policy specialist on NCSL's health team. I'd like to welcome you to our briefing today. We're going to focus on collaborative responses to our nation's mental health crisis. Before we get started, a few words just about the National Conference of State Legislatures. We're the country's most trusted bipartisan organization, serving legislators and legislative staff for over 40 years. NCSL is the only organization that serves all of our 7,383 legislators and more than 25,000 legislative staff. We work to promote innovation, create opportunities for lawmakers to share knowledge, and ensure that states have a strong, cohesive voice in the federal system. We're grateful Congress has recognized the importance of mental health issues and that they're looking at this with common sense solutions. We hope today's briefing will be helpful to members of Congress and the administration. We're encouraged and look forward to partnering with members of Congress as they delve into the issues surrounding mental health. Today, we are joined by 3 state legislators who are deeply involved in mental health prevention and crisis response in their respective states. Dr. and Senator Ralph Alvarado from Kentucky is chair of the Health and Welfare Committee and has served in the Senate since 2015. Assemblywoman Carol Murphy serves as Majority Whip in New Jersey and is vice chair of the Judiciary Committee and has been in the General Assembly since 2018. And Representative Steve Elison from Utah serves on the Health and Human Services Committee and has been active in health policy for many years. He's been with the Legislative Service since 2011. They will also be joined today by my NCSL colleague and expert on substance use, harm reduction, and suicide prevention, Senior Policy Specialist Charlie Severance-Medeiros. Thank you all so much for joining us. I think before we turn it over to our panel here and jump in, I'd love to talk with you, Charlie, a little bit to help me set the stage. First, I think there's a few reasons that we're meeting today. One is that it's May, so it's Mental Health Awareness Month. And we could think of no better way to highlight this than really to talk about mental health and what are some of the actions and things that are happening in our states. But 2, we also know that states have been responding to mental health challenges and treatment access for years, and it's only been exacerbated by COVID-19. It's unfortunately highlighted many health challenges, but we know that adverse effects on mental health due to isolation, missed medical appointments, and inadequate crisis system has been really difficult for not only individuals, but it can often burden the healthcare system, state budgets, and it can drive involvement into the justice system. I'm wondering if you can speak just a little bit broadly about what we've seen in the last few years with regard to state initiatives and actions and what we could see coming in the next few months.
Yeah, absolutely, Tammy Jo. And thank you for including me on this panel and on the conversation today. And thank you to our legislators and everyone else who has joined us for this conversation today. I think you really teed it up pretty well. I think that really here the issue is that states have been dealing with a number of compounding issues, right? These mental health problems that we've been having, these behavioral health problems aren't really new. We've seen suicide increase by more than 30% since 1999. And just the other day, new CDC data confirmed that we'd had over 1 million deaths from drug overdose in about that same time frame, including more than 100,000 deaths in 2021, which was a record. We had never seen that many overdose deaths in a single year before. So obviously during the pandemic, states have been taking a number of actions to try to increase access to care, and a number of those have been around things like telehealth and sort of taking advantage of different federal flexibilities to connect people to care for substance use disorder and medication-assisted treatment. I think where I really want to focus though today, and where I think that some of our respondents will be able to sort of shine an even brighter light, is around the rollout of the 988 Suicide and Crisis Lifeline. To sort of level set there, I think that folks are aware that this was initially created back in 2020 at the federal level, with the idea being really that that 3-digit number would be easier for folks to remember, right? So I think that if I were to take a poll right now of everyone on the call and see how many people know what the 7-digit number is, most people probably are not going to know that off the top of their head. But I think that most people do know that if someone is in a physical crisis, we can just call 911 and they'll be connected to care. So that was really sort of the impetus behind creating the shorter 3-digit number. And they've given us, the federal government created sort of a 2-year interim period for some sort of things at the back level, some technical changes at the back level to take place. And also to give states time to sort of figure out how they're going to respond to the implementation of this lifeline. So starting on July 16th, 2022, anyone calling into this lifeline is going to be connected to care, right? It's either going to go to the nearest call center in that state, or to the nearest call center in an adjacent state, or to the backup call center in New York City. So that part is already set. Anyone who is going to call in starting July 16th of this year is going to be connected to some form of care. But there are some options that states can take to sort of push it a little bit further. So it does create the option for states to create a surcharge on telecommunications fees. This must be similar to surcharges imposed to support 911 and must be used to support responses to calls to the 988 hotline. A number of states have also looked at using some of their general fund dollars to support the implementation of 988. And a few states have even looked at doing Medicaid waivers. So using an 1115 Medicaid waiver to support some of those responses to calls to the lifeline. And what are states doing with that money? Part of that is expanding call center capacity. So making sure that folks can actually be connected to local resources. Obviously, someone calling into the call center at New York is not going to necessarily be able to be connected to, local care organizations, local, Alcoholics Anonymous meetings, that sort of thing. Those local call centers can really be resource hubs for local community resources. But states are also looking at supporting things like mobile crisis units. So actually taking care to people, especially in more remote areas or in rural areas where we might not be able to physically bring them into an office. And also looking at things like expanding access to crisis stabilization centers. So that creates an opportunity to take people, out of an emergency department or out of a jail potentially, and get them into sort of more specialized care more quickly. So I'm going to quickly share my screen here. We've seen over the last 2 years about 20 states that have enacted legislation related to the 988 lifeline. A number of these states like Colorado and Virginia have actually gone ahead and enacted that surcharge fee that we talked about. Indiana is a state that has allocated some money from its general fund and also has pursued a Section 1115 waiver. Other states like Nebraska and Texas have created study commissions to figure out what the best way is to sort of support implementation in their states. And other states like Oklahoma have just done some sort of raising awareness of this new lifeline. So Oklahoma specifically enacted a bill that would require the 988 lifeline to be included on some student ID cards. And so I think that, Tammy Jo, I will stop there because I think that our panelists, our legislative panelists, have a lot more specific information they can share about the lifeline, and turn it back over to you.
Well, thank you, Charlie, and thank you for sharing, just some of the priorities and trending topics and conversations that we've seen. I think you really highlighted how many areas we could really talk about today with mental health and what states are looking at. And so I think I want to dive just maybe a bit more specific, and I'm going to turn it over to our members here. And I'll ask Representative Eliason to kick us off. I'm curious if you can just share some of your top priorities within your states and remind us where you're joining us from.
Yeah, thank you. Representative Steve Eliason, joining you from Salt Lake City, Utah. So I think one thing that I will touch on that is tied into this issue, and it's really important, but hasn't gotten a lot of attention, is we passed a bill to create a statewide warm line. During the call today, we'll hear a lot about the National Suicide Prevention Lifeline, but Utah kind of got a head start on this. And one of the key lessons we learned is there's a lot of people that call the crisis line that are not quite in crisis yet. There's different levels of acuity. And just like in healthcare, you want to prioritize the most acute patients to the most skilled clinicians. And so I sponsored a bill that created a warm line, and it's publicized around the state, and it's for people just needing someone to talk to, not quite in crisis. Those staffed by peers, so individuals that don't necessarily have a degree in mental health but have a lived experience. And if a caller calls the warm line and they are in an acute suicidal crisis, they do a warm handoff with somebody at the same center that is on the crisis line. Likewise, when somebody calls the crisis line and just wants to talk for a long time and maybe isn't, as high acuity, they'll do a warm handoff back to the warm line. From a staffing perspective and a cost perspective, having a statewide warm line is critical. It's very difficult to find a sufficient number of clinicians to work the crisis line, and peers are a lot easier to hire and frankly better suited for a lot of people. So if your state doesn't have a warm line, I would suggest looking into that.
Thank you. Thank you for sharing. I think you're right too. That is an area that we also get a lot of questions on. Senator Alvarado, I'd like to throw that same question to you. What is happening in your state right now?
Well, thanks for having me on. First of all, Ralph Alvarado. I serve in the Kentucky State Senate, and I'm also the chairman for the Senate Health and Welfare Committee. A lot of our priorities, we just finished up last year with a severe mental illness task force and kind of addressing a lot of issues, and it's pretty broad as far as the thing that we covered. I think the biggest things that we focused on was really our development of a workforce. We've done a lot of work on trying to provide as much access. We're a rural, state, small state, poor state. We have areas that are urban and that you can find medical professionals, but in our rural areas, it's very difficult. We find more and more psychiatrists, nurse practitioners who do psychiatry are just taking cash only. They don't want to deal with insurance companies. And so, for example, in child psychiatry, we have about 1 million children in the state and only about 59 to 60 child psychiatrists in the entire state for those kids, half of which don't take any insurance or cash only. So really, really limited on resources. So we've really done a lot of work on our telehealth. I think we have one of the more competitive, if not one of the top 2 or 3 telehealth bills in the country. And every year we seem to be doing things to make it easier. Just as long as you're licensed in the state, you could be anywhere in the world to provide care for someone in Kentucky. And we've continued to work on that. We've also expanded definitions of qualified mental health professionals. So that's a lot of the things we've been working on. The other big thing is on housing. We have a lot of struggle. We find that a lot more of our patients are now finding their way into long-term care facilities, skilled nursing facilities. So in nursing home settings, in our prisons, a lot of these folks obviously are there and have nowhere else to go. And so we're trying to find a way to try to use, apply for a Medicaid waiver. We passed a resolution to direct our cabinet for health and family services to apply for a Medicaid waiver to provide supported housing, respite care, supported employment to individuals with severe mental illness, to try to address a lot of those issues. And so those have been the 2 biggest. I think there's a lot of issues out there. We've done a lot of things to address a lot of our first responders during the pandemic too, that have taken on the brunt of a lot of stress, a lot of mental illness, a lot of innovative work in our schools, just kind of safe zones for kids. We just passed a bill this year too, to allow children to use kind of mental illness or mental illness day as a legitimate excuse not to go to school. And that had some more resistance than you would think in the legislature, but it was something that at least it requires local school district attendance policies to include provisions for that, so that kids, if they're having a lot of stress, can use that as an excused absence. So a lot of work, but mostly it's around development of workforce really, and housing are the 2 biggest things.
Thank you. Thank you for sharing. I made note of a few topics here I would like to go back to, but I think first I would like to talk a little bit about, that workforce component, as well as just 988 rollout and what that's looking like, particularly in your state. So Senator, I'll throw it back to you to kick us off a little. Charlie highlighted the work that's happening around the 988 rollout. And, it's important, hopefully, for our federal counterparts to just be able to hear how it's going, especially given that this was a state federal initiative. So I'll have you start us off there.
Sure. So Kentucky kind of currently operates a 24-hour, 7-day-a-week crisis hotlines, and they're in all regions of the state. And it provides like a mobile crisis intervention and stabilization units for people when it comes to crises. And so We've received obviously a lot. Everybody's received a lot of ARPA funds, COVID funds. I think the executive branch is using roughly $3.3 million for the implementation of the 988 Lifeline response system. It's also going to allocate a portion of its crisis funds to implement text and chat abilities in preparation for that 988 Lifeline implementation as well. There were some grants from a nonprofit called Vibrant Emotional Health that offered $340,000 back in May of 2021, nearly a year ago, to start this process going. There was a bill proposed this past year, I think it was House Bill 373, that would have put a 70-cent surcharge onto cell phones to pay for this service, but that didn't pass in this past session. But we did put money into the budget. We appropriated about $500,000 in each year to support the Kentucky Rural Mental Health, Suicide Prevention, and Farm Safety Program that we've labeled Raising Hope Initiative. We have a lot of farmers and a lot of folks who've gone through some tough times as well in our rural communities. And so the Department of Behavioral Health is going to coordinate with the Department of Agriculture here in Kentucky and also with the University of Kentucky for ag health and injury prevention to enhance awareness of this 988 line, particularly in rural communities. I think we do a pretty good job in urban centers, but a lot of rural folks may not use cell phones as much. And so this is going to be an opportunity to promote a lot of that. And so money was put specifically into the budget. I think that's the main thing that we did this year for 988. It's always difficult for us to get any kind of what's perceived as a tax increase on cell phones in lines, but it's going to be the way we're going to be able to get this covered. And I think people are more and more aware. We've just seen the statistics you just heard of what's happened this past year in terms of deaths that are increasing. Everybody knows it's one of the biggest things on our agenda every year as a state and in most of our states nowadays. So I think we'll probably see that bill coming back in the future as we see the need and the demand for it. If there's a delay in calls, you'll probably see a call to try to put a surcharge onto phones. A lot of people just view this is a federal mandate that was unfunded. So if there are people that are watching, we'll welcome funds to help implement those things in our states. But that's what we've done as a state, is taken funds and put it in our budget to make sure it gets covered.
Thank you. No, thank you for sharing. Really appreciate that. And I know similarly in Utah, Representative Elison, you all have also been working on some kind of crisis response. You've had the 988, rollout conversation as well. So just wondering if you could talk broadly to what that's like in your state and some other initiatives you've got around behavioral health.
Yeah, thank you. So several years ago, myself and Senator Dan Thatcher tried to get a 3-digit number in Utah to access the crisis line. When we failed, we went to our federal designation, Senator Orrin Hatch and Congressman Chris Stewart. They sponsored the federal legislation to get the 988 number going. Well, in the meantime, we started working on building out our crisis response system and put a lot of money in promoting help-seeking behaviors like calling the crisis line and calling the warm line. This graphic that you have put up on the screen here is a really good summary. We sometimes refer to it as the crisis funnel. The goal is to keep individuals as high up, treat them as early as possible to prevent them from going further down the funnel. You can see on the left that as they go down this funnel, the costs go up dramatically. The impact on the individual is much more substantial in terms of taking them out of school, out of work, out of their home. So we spent a lot of funds on community education programs. We created a program called the Live On campaign, Live On Utah, and a lot of billboards, social media types of messaging to educate people about what suicide prevention looks like. Primary and specialty mental health care. 2 bills I sponsored in this category. One provided grants for healthcare institutions to implement zero suicide initiative programs in the healthcare setting. That's a national best practice. So many individuals that die by suicide have seen a primary care provider or specialist in the weeks or months leading up to their death by suicide. So being able to identify those patients and put them in a pathway of care that can help prevent that is critical. A bill that I sponsored last session created funding, a grant program for the collaborative care model. If you don't know what the collaborative care model is, I'd strongly encourage you to read about it. It's one of the best ways to increase access across the nation, where in consultation with a psychiatrist. A primary care physician also works with a behavioral health care manager, often a social worker, to treat the 80% of patients that don't have a serious mental illness in the primary care setting. 24 states have opened up the collaborative care codes under the Medicaid, under CMS. Those codes are available. Unfortunately, only half the states have taken advantage of them. So the grant program that we rolled out is trying to encourage healthcare entities to start offering collaborative care. As we go down the model here, then we have the Crisis Contact and Referral Center. That's where calls to the National Lifeline go. As Charlie mentioned earlier, a lot of people don't know the 7-digit hotline. I don't, because the lifeline is actually 10 digits, 1-800-273-TALK. A little known fact is that pretty much anybody who calls 988 nationally on a cell phone now, it will be routed through the National Lifeline. They just haven't promoted that yet, but once it does get promoted, we'll see a big increase in calls. And if a state is not prepared, they're going to have long wait times and a lot of disappointed individuals. Now, a key part of what we've done in Utah, and Tennessee's done, or Kentucky and Tennessee have done components of this. Senator Alvarado mentioned mobile teams. As you can see, for every 100,000 people that call the crisis line, they can stabilize about 90% of those people. About 10% will need a visit, a mobile crisis outreach team, typically a licensed clinical social worker and a peer. It's like a mental health ambulance with no flashing lights, no uniforms, and typically no bill. They can stabilize about 90% of the people at the location they go to. And then about a small percentage of those, about 10%, will need to go to a short-term observation facility. This would be a crisis receiving center. A bill I sponsored here in Utah, we got a Medicaid code opened up to a bundled rate for crisis receiving centers for Medicaid patients, which is critical to their financing because so many of these patients are on Medicaid or eligible for Medicaid. And then in 23 hours, those people can typically be stabilized. And for those that can't, then they move into subacute or acute inpatient hospitalization. Those costs, as you can see, go up dramatically. So as we talk about improving access to 988, it's critical that not only do we have someone to call, for these individuals to have somebody to call, we need somebody who can respond and a place for them to go. So I'd encourage states to look at their whole crisis continuum and make sure they're building out the whole system.
Thank you, Representative. And I think that's a great segue to start thinking about, another area that we get a lot of questions on, but we've also really been seeing a lot of state action, especially in the last few years, is around that crisis response. For instance, we know that first responders are usually the first response to many crisis calls for folks, and that might bring them more into the justice setting versus a mental health or an appropriate healthcare setting. I'm curious, if you could share a little bit about what has happened around the justice involved population within Utah, and what's going on there is kind of as far as your prevention as well.
Yeah, thank you. So I think if you look at these costs, you can see $40 a call for the Lifeline or less than $400 for mobile crisis team. The current model that we've dealt with for decades, both in Utah and across the nation, is that so many individuals with a mental health issue are being criminalized. And there are two options: are either an emergency room or jail. Neither of which are ideally the best models, particularly jail, because mental health treatment is so rarely available in institutional settings like that. So Utah funded the creation of 5 statewide crisis receiving facilities that covered about 85% of the state. These are 23-hour facilities. They're basically psychiatric emergency rooms. And the cost for those is, here it says $1,250. It's actually typically a little bit under $1,000. And law enforcement has strongly supported that bill, HB 32, several years ago, because they know that if they take him to jail, they're typically going to be booked, released, and back out on the street and it's a revolving door. And I think Einstein said insanity is doing the same thing over and over, expecting a different result. And we've effectively been doing that. So these crisis receiving facilities, the goal is to diagnose them, try to get them on a pathway to care, and then the charges can be dropped if they comply with that. A lot of times officers now can say, I have two options. We can either go to jail, or if you agree to get treatment, I can take you to the crisis receiving facility. I've had an opportunity to visit these in a number of states, including here in Utah, talking with individuals. They said, I've never been treated like this. They've always just punished me for my mental health issue, my substance use disorder issue. And they said, that's so refreshing. And so I think it's a key element of criminal justice reform. And it's a lot more than an ounce of prevention. It's kind of a pound of cure up front, and it's reducing the impact on our jails and our emergency rooms. Keep in mind, an average visit to emergency room may be $2,000 or $3,000. A lot of these individuals are on Medicaid. To the extent you can get them better care at a much lower cost, it's such a better answer all around.
Yes, thank you so much for sharing that. I think those are perspectives we've heard from a lot of our other members. And specifically, I'm thinking Senator Alvarado, I know that Senate Bill 90 in Kentucky has looked at some of this, and I know that there's been a lot of work within Kentucky just overall to focus on, healthcare services and treatment and access for folks that might be involved in the justice system. Can you speak to what Kentucky's doing a little bit around this population?
Sure. And, I think if you look at our state's jail population, we were one of the, most incarcerated states really in the country. We started looking at that, the costs that were there. Some of our jails were probably at levels where the federal government might have to step in and take a look. And so the pandemic allowed a lot of people to be sent home and to serve some more of their time with home incarceration. But Senate Bill 90 was one that was a good bill that we just got passed. And see if I can get it on here. It was sponsored by a very good friend of mine who's the Judiciary Chairman for us, Senator Whitney Westerfield, who does tremendous work when it comes to this space. But it's a pilot project, basically. It's establishing a behavioral health conditional dismissal pilot program in at least 10 of our counties. It's going to start on October the 1st of this year. It's going to continue for 4 years total. Eligible individuals basically get an alternative to receive treatment for a behavioral health disorder instead of incarceration. And it results in the dismissal of the criminal charges upon the successful completion of the program. So treatment requirements would include access to medical treatment, counseling, education, vocational counseling, and training. There are multiple reports that are done. So you get reports at 14 days of the program. They report the individual's age, gender, race and ethnicity, housing history, educational history, employment history, past treatment, past involvement in addiction, and criminal history. And then another report at day 28, which shows the progression of the program with continuation of the program, status and kind of treatment that they're getting, employment training, educational training, housing status, and other information that they want to provide. And then you get quarterly reports after that with the results of the program so that people are monitored pretty closely. The people that would qualify for this are people that have either been charged with a misdemeanor or a Class D felony that is not a violent or a sexual offense, or people with interpersonal protective orders that might be out there. You have to be able to offer recovery services. So that includes things like MAT for a lot of these folks, so medication-assisted treatment, counseling. You have to be able to provide substance abuse education, vocational training, literacy training, community service opportunities for these folks, inpatient treatment if it's needed, because some of them may require that, restorative practices to be able to do some kind of restorative therapy with the people that they've harmed, and then also housing assistance, which is still a major issue for us. The Commonwealth's attorney, kind of our district attorney, is the individual who gets them to determine that eligibility, and often will look at a case and say, I think this person would be eligible. They approach the individual and say, here's an opportunity I'll give you, and then they can make the decision if they want to proceed with that. And then within kind of 72 hours of an arrest is the jailer, basically is the person that's going to get to identify the individual, contact a qualified mental health professional to do an assessment, and then they can go to the Commonwealth's attorney and say, we think this would be an opportunity for the person. It's a constant, this is a debate always for us. We have a lot of people who are former law enforcement who serve in our legislature who still have a hard time grappling with people with mental illness. And they say, well, if some of these folks are bad people and they need to be punished for the crimes that they perform. And it's trying to separate, and again, we've made some exceptions so that if you're violent crimes, sexual offenses, we're not going to include you in that group, but other people, and a lot of them are Class D felonies that would have an opportunity to get their records, cleaned up and get treatment at the same time. And so we're going to pick 10 counties. There'll be some rural, some urban. There are several Commonwealth attorneys who want this program in their county, and there's some who don't. So we're going to give it an opportunity, give it a 4-year course, and show that it works, I think. And if it works, then we'll have an opportunity to roll it out throughout the entire state. Another thing that we often talk about is something called Tim's Law here in our state, which you talk about the revolving door of people coming in with illness. I mean, as a doctor, I've seen that also, people coming to nursing homes, often who will have mental illness like schizophrenia. If they're on their medications, they do great. They do wonderful. But they get out, they get tired of taking their medicines, they stop taking their medications, a problem occurs, they do something that's criminally illegal, basically, and they wind up getting arrested, go to jail, get discharged, come to a nursing home, and they're under someone else as a guardian over their care. And when they get on medicines, they look great, and they go, Doc, can you please help me get off? I want to get my rights back. And you help them get their rights back, only to have them go out, stop taking their medicines, and it just becomes a recurring process. And so we passed a law here that basically, would allow to have court-ordered basically treatment or mental health treatment for a lot of people that go through this. And so a lot of our judges, some of them don't like it. Some of our, county attorneys don't like this. They think it takes people's rights away. But we've made some changes in that to make it easier to allow the court to take in that individual's case by individual basis, to be able to interview the person themselves to make that determination. So we're trying to make that as easy as possible to be able to stop that cycle and let the court step in and say, you take your medicines, you keep doing what you're supposed to do. We won't, you're going to be able to be out in the community and do your thing, but it requires a lot more oversight over that. So we've taken a lot of different approaches on trying to stop that, but I think this one is going to go directly at people who are in jail, to identify those folks, be able to get them out, get them the treatment they can, and hopefully, again, just like you heard Representative Eliason say, that it's give people another chance who are going to say, hey, for the first time in a long time, you're not looking at me just as a criminal. It's somebody who needs some help from a medical angle on it. So we're looking forward to see how that'll work.
Yeah, thank you. Thank you for sharing. I can just say from an NCSL perspective, we'll also look forward to seeing and hearing more about that work. And it fits really nicely, and just with the continuum of care that we know a lot of states are really focused on for mental health services and behavioral health broadly. So thank you for sharing that. We earlier brought up also youth, and I think that that's a major issue. We obviously I would be remiss if we didn't bring up. And Assemblywoman Murphy, I know that this has been a space you've worked a lot in as well, and it has been risen a bit as a public health concern right now for our youth, and so much so that the Surgeon General and the President have both highlighted it at that national concern. I'm wondering if you can share just a little bit here for your state priorities and your interest as far as youth mental health goes.
Yeah, so thank you, and thank you all for including me in this, and it's great to meet with all of you. So mental health. We're in the process of doing our budget here in New Jersey, and between meeting with the Department of Health Commissioner and our Department of Human Services Commissioner, and just as of yesterday, we met with our Department of Corrections Commissioner, and working on this budget. But prior to that, even just talking with kids in our schools, and that's one of my priorities. Is I have a chance of talking to kids in schools, whether they're in college or high school. And I have, a great amount of respect for all of them. But as you bring up youth mental health, and we're talking about budget, one of the things that we're assuring in our budget this year is that there's money put back in the budget, and there's money that is still there for the budget to help with cover all kids in New Jersey. And why is this important? Because there's so many kids who come from families who are economically challenged, who can't afford health insurance, or cannot afford enough health insurance, or does not have the right coverage, or can't afford to go to some of those facilities that provide that exceptional quality care. So as we start talking about budgetary moves, we're talking about cover all our kids, which I think is extremely important to assure that there's money put in there for all kids who can be covered, similar to CHIP. But more importantly, and I say this because I have like I said, speak with a lot of youth. I have an opportunity to tell them one very important thing. It's okay to feel bad, but it's not okay to do it in silence. And our kids nowadays, because of between COVID and the unusual stresses that are put upon them for many reasons, in many places around our state and around the nation, they tend to absorb all of this, but they stay silent, and that's not helping them out. So one of the things that, as we start talking with our school boards and our superintendents and our principals and our teachers especially, one of the big initiatives that I started before COVID, and I will be picking this up again probably in the fall, is wellness center rooms. And what this is, because this is so important, when I first saw it, I went to a high school down in Ocean City, New Jersey, and they had instituted this mental health wellness room. And it's completely decorated, designed by high school kids. And what does this room do is allow them, because it takes the stigma, and that's the biggest thing, the stigma around our kids in college. So it takes the kids that are in high school, the opportunity to go to this room. Everyone is welcomed. Every single person is welcome, and it's manned by that person in school, whether it's teachers or counselors or faculty or whomever it is. They man the room, and the high school kids will go have lunch, study hall, whatever. And it takes away that pressure of being known as somebody who may have an issue, because everybody goes through bad days, right? I mean, kids may be going through divorcing parents, they may be going through a bad day at school, or it may be even more severe where they have a lot more challenges that they are dealing with. But it allows for that teacher, counselor, whomever is manning that to take a look at the kid and say, hey, John, why don't you come with me? Let's go talk and see what's going on. And they take them to a room that's off the side of that room. And what this does is give that student that permission to talk, because no one knows why he or she is there, because they're all there. They all have that chance to utilize this room. And when I say it's decorated couches and chairs, and it makes them feel comfortable as if they are in a place where they can relax. And if a teacher or whoever mans it sees that student having an issue, they can approach that student and talk to them and hopefully make them feel comfortable enough to go and talk to them. Because, right, our youth is 90% of their days are in school, and our teachers, as much as, they teach, there's just so much put on them besides being babysitters and teachers, and they also have to be some type of counselor in some form or fashion. They have to identify problems. So that's why I also put in a bill that would allow for first aid training on mental health for our educational professionals, not only the school board members, but our teachers and faculty, as well as first aid mental health for people in state government, right? Because even kids who intern, maybe they're in college, they may also be experiencing that same type of issue. And we should be able to identify it. So when we talk about the youth, it hits everywhere in the nation. Every single state is grappling with our young folks being able to deal with those issues that cause them some type of distress. And so many things are contributed to that, such as our overdose, that, our addiction to drugs and alcohol. That is also, not all of it, don't get me wrong, not all of it, but a lot of it has to do with the way kids deal with their health issues and the way their self-esteem. And I think COVID in this daytime has brought that out more of our kids, especially not being able to get to school for the past 2 years. They've been bottled up. There's no socializing there. So I think there's a lot to do with that mental health that we have to pay attention to. There's a lot more work to do. I think we've done a lot in New Jersey to address it. We have a lot of bills that address it. And I don't see it being an issue that's going to be resolved anytime soon. And I think the more we have open and honest conversations about it as a group, and especially honest, I say this, can't stress this enough, honest conversations about it, because you're not going to improve anything if you don't have that honest conversation, and everything starts with education. So, if you have to be educated and something to be able to resolve it. So I think that's where, this is why I could talk about this forever. And because I think it is an important subject that we have to deal with as a nation.
If I could jump in real quick on what Carol just said. I mean, my local high school, I just went for a visit. Session ended for us, and I stopped in, and they've got one of these rooms. It's where the Clark County Cardinals. So it's like, they call it the Nest, and it's a room with beanbags and kind of low lighting, a little bit of modern theme music in the background. No cell phones are allowed.
Right.
So they come in, they got to turn those off. They don't allow it in there, and you got aromatherapy going on. And when I talked to the teachers and the counselors who were in there, they said, yeah, we don't want it to smell like, like a high school, like a high school locker room gym or something like that. But you walk in and you immediately, I walked in like, this is nice, it's decompressed, the lighting is dim. And they showed me some of the notes from these kids, just from having that in their school, thanking the people that are there. Someone will listen to me and someone understands me. And the conversations that are had, everything's just real quiet. And it's an opportunity for decompression during this time. And really, it's a great idea. I thought it was fabulous. So
Yeah.
it was good thought.
It is. And if I may add just one more thing to that, and then I'll move on, is, what, if talk to your high school kids, talk to whether you have kids or you have friends of kids, or if you're a legislator, invite some of your high school kids, especially seniors, around the table and talk with them about this issue. Because one thing that they are all very passionate about is protecting their fellow student, to assure that their fellow student isn't made fun of. They don't feel as if they can't have these conversations with somebody, but more importantly, they want to make sure that their parents understand where they're coming from, because sometimes, parents of children who are going through something may disregard it as, oh, he's just having a bad day, or we all went through this. So I think that's another issue, is making sure our parents are involved in these conversations as well with our children.
Thank you both for sharing. I think in listening to you, a phrase that's really coming up for me is just creating that safe space, whether it's in that high school or maybe at home, or creating those conversations with adults. And I'm going to pull back in Representative Elison here. I'm going to jump around a little bit and say that, I know a lot of work that you've done in Utah has been also around that suicide prevention, creating that safe space, connecting with youth. And one of the ways that it's been done is through an app that you use, and we have a lot of questions usually about it. So if you could tell us a little bit about Safe UT, I would appreciate that.
Yeah, thank you. So while it's an app, there's thousands of mental health apps. We like to refer to Safe UT as a system of care. So we've had this rolled out for about 6 years now. And the data that I'm privy to, we've had 5 years of declining youth suicide numbers. Suicide is the leading cause of death for children ages 10 to 24 in the state of Utah. Nationally, it's the number 2 cause of death. And so when a 15-year-old dies, they may cut 60, 70 years off of their life. And I calculated we were losing about 3,000 years of potential human life in Utah with just the children that we were losing to suicide. So years ago, me and Senator Dan Thatcher rolled out a bill to create an anonymous school safety tip line. Kind of had its genesis with the Columbine shooting years ago in Colorado. And is kind of an experiment. We said, well, why don't we, in addition to giving this opportunity for an anonymous tip through an app, let's allow students to connect with a licensed clinical social worker and just allow them to chat with that person anonymously and confidentially. It exploded. We've had to come back in numerous times we first funded it with like $115,000 of ongoing funding. And we've had to come back in a number of times to supplement it as the program grew. It was voluntary. Basically, every public school in Utah has now rolled this out. This is grades K through 20. So all of our higher education institutions have rolled this out also. This is up on the screen, a summary of statistics for just the past year, basically. We've had the chats are the anonymous, confidential, at no cost chats between a student and a licensed clinical social worker. So we've had over 28,000 chats, which is comprised of over 1 million, we call them threads, back and forth messages. We've had just under 9,000 tips. And when we rolled this out first, it was focused on school safety. As you can see, of the almost 9,000 tips, only about 388 of those related to law enforcement or potential school threats. However, that's about one a day that we're getting. And we've had guns confiscated, fully assembled pipe bombs from children's homes. And so it's serving its purpose. However, the number of tips that come in, the top 5 tip topics are about suicide, where somebody says, my friend said they're going to take their life tonight and I don't know what to do. Bullying, which we know is a key factor in youth suicide and mental health. Students in crisis, other related mental health and depression related topics. And during the pandemic, this was especially helpful because so many students didn't have access to their schools and their school counselors. We found the anonymity and the confidentiality related to this took the barriers down. Plus it's open, it's never closed, 24/7, 365. The crisis line is staffed. I took a psychiatrist that was visiting our state a few weeks ago to visit our crisis center, who's on a school board. And just the time I was there were 16 students in the middle of the day chatting with crisis workers. We had so much success between the Safe UT program that we then rolled it out for the National Guard, because we know that suicides amongst our active duty and veterans is so high. And that's called Safe UT NG. It's available for National Guard members as well as their families. And then we rolled out Safe UT Frontline, which is for law enforcement. They're more likely to die from suicide than, in the line of work. Firefighters, same applies, more likely to die from suicide than from the hazards of their job. And healthcare workers who have been under tremendous duress during the pandemic. The only cause of mortality that's greater for a physician than their patients is suicide. And so this is an anonymous and confidential app that connects them with the same crisis center. It's the same crisis center that answers our National Suicide Prevention Lifeline calls, as well as our Worm Line calls. And we're seeing a very nice uptick in these vulnerable professions utilizing this app. Now, one of the key things about this for both law enforcement, firefighters, National Guard, it's outside the chain of command. So they're not worried about how's this going to impact my job? Is my supervisor going to find out that I'm struggling? It's completely outside of that realm. And we're seeing great success across all 3 platforms. We don't think it's a coincidence that over the past 5 years, we've seen the uptick dramatically in the usage of Safe UT and a corresponding decrease in the double digits of our youth suicide numbers.
Thank you. Thank you for sharing. And when I first heard about it, I only knew about the one version. So glad to hear that it's going well and it's an initiative that you all are expanding. So I would love to open it up to the audience. And while I turn to them and ask them to start putting their questions in the chat, I'm going to give you all one more. And in about a minute, I'm going to ask you for a multi-part question. It's a lot in one amount of time, but I feel good about it. So if we were to think about what is potentially a comprehensive mental health approach look like in your state, would it include particular services provided, access, sustainability? What comes to you? And then what would you say is kind of a specific federal support that you think might be helpful? We're going to go rapid fire, and I'm going to pass it to Assemblywoman Murphy first.
Okay, rapid fire, here we go. So I think we need to have urgent cares directly dedicated to mental health and suicide. And I think how feds can help with this is by helping out with the money situation to assure that everyone in their state have access to the urgent cares that can deal directly and specifically with mental health.
Thank you. Senator Alvarado, you're next on my screen, so we'll just go to you.
It's a loaded question. There's so many, all the things you mentioned just in your introduction are things we'd like to have. The things from the federal government, the less strings you can put on us, the better. Give us the ability to be innovative. All too often we have a lot of restrictions on how funds can be used. And if you let us figure it out for our states, we can do really good work in finding that. But I think really We need to increase providers. We're having a hard time getting people to get into this field as far as physicians and nurses and nurse practitioners. Housing is of crucial importance, at least it is for us here in Kentucky. And we have to be able to have quick access for these folks. And really, it's the less restrictions we can have from the federal government on our states and the funds that are allocated for this, give us the ability to be innovative with it. It's what I would request.
Thank you. And Representative Ellison.
Thank you. Rapid fire. And I met with the chairman of the FTC on this in person, giving geolocating ability to the National Crisis Lifeline. They have it for 911. So if a caller calls and says, you know, I'm standing on the edge of a bridge or a train track, if they called 911, they could geolocate them. If they call 988, they don't have the functionality. That's a federal issue that needs to be solved, and it needs to be solved quickly. Another national issue is back in the 90s, the federal government quit funding GME, additional medical residencies. We found we have an acute shortage of psychiatrists. And so in Utah, I've run several bills where the state is funding psychiatry residencies because it's one of the most chosen specialties now for graduating medical students. There's not enough residencies for them. And so I would encourage states, they can do that on their own, but I would say if the feds put matching money, they could help leverage local money. And that's a critical area because we have willing people, but we don't have the residencies for them. And the last thing I would say is on the Medicaid, Medicare front, make sure there's parity in funding for virtual visits. The public health emergency has suspended that, but once that's over, those should be treated exactly the same between those two programs.
Thank you. Thank you all for sharing. I appreciate your quick thoughts there. I know that it's a bit of a loaded question, but I do have one question right now that I'm seeing in the chat, and it does seem to be directed towards you, Representative Ellison, but you know, if anybody else would like to respond, I think that's great. And it's really just generally how much is focused on appropriations within the legislature versus some other policy needs.
Meaning versus mental health?
I'm going to say yes. It's a little more general in the question, but we'll direct it there.
Yeah. So what I found in Utah, and I'm sure this is the case in other states, is that these issues shouldn't be partisan. Bipartisan at a minimum, nonpartisan ideally. It affects everybody. And we've had huge support, over nearly 95% yes votes on nearly 24 mental health bills that we've run. And some of those have significant fiscal notes, you know, costs associated with those, like our SB 155 a year ago was 17 million of ongoing funding to beef up our crisis services, our crisis line, our mobile crisis teams. So people just need to swing for the fences because the need is greater than ever. And if people really study this, they realize that investing in these issues can head off much more expensive services that so often impact states' Medicaid budgets later on. And so, you know, looking for, not all mental health legislation has fiscal notes attached to it, but looking at the full continuum from access, training, workforce, crisis services, and then just looking into some of the other policies related to mental health, which are numerous, to see where those can be addressed. I think you'll find that there's great support for that. As mentioned in the federal legislation, states can assess a surcharge to fund 988. In Utah, with record budget surpluses politically, that wasn't the main option. So we just funded out of our general fund. But that's a resource that if states don't have their general fund dollars, I'd look at doing the surcharge, because mental health should be on parity as physical health. And I think every state charges 911 surcharges for that service.
Thank you, Representative. And, you know, I think I'm going to throw this next question kind of to all of you. We talked a lot about different warm lines or crisis lines or 988, you know, what else is coming? And so a question in the conversation here is around, you know, have you seen any abuse of these tip lines to identify kids as threatening because another child may want to get them in trouble or might misinterpret what they've said, or any type of conversation or feedback around that?
I haven't heard
Um,
that yet. I mean, these are fairly new. We haven't heard that concern as of yet. So, but that hasn't. I mean, I'm sure we'll probably get at some point someone who might use a line inappropriately, but that's true of any emergency line that you have out there. So I don't know that it's going to be a rampant problem. I haven't heard that yet, but again, we're still kind of in this infancy of it. So,
I'll take a quick stab at that. So we've dealt with this issue for years, and there are students that abuse it to bully other children. And we first started with a private vendor, and then the state of Utah just paid the University of Utah to write our Safe UT app from scratch. And in our terms of use, it says that if it's a life safety issue, meaning somebody's at risk of dying, or they're using it to submit fake tips or bully somebody, their URL can be breached. And in almost every situation where a child has been using this to send in a fake tip or use it to accuse another student of something falsely, we have found that that student is in desperate need of mental health services themselves, and has actually been an opportunity to get those students into treatment to figure out why they're acting out the way they're doing. So while it is an issue, just before a student submits a tip on our app, it says, there's penalties for submitting a fake app or a fake tip, and that helped reduce it. But then they follow through if they find that it is being abused. In our terms of use, it also says that if it's a life safety, we can breach your URL. We do that about twice a week, where a student is at imminent risk of death. And so far, we have not lost a student yet when the emergency crews have been dispatched while we keep the child talking and can get there before it's too late.
Thank you. And Assemblywoman Murphy, I know that you had also unmuted. I didn't know if you would like to add anything else.
No, I just want to say we haven't heard too much about abuse, but I agree. If somebody's going to use it to bully or intimidate or use it against another student, there should be some consequences to that. And I was reading, somewhere else that it's definite, and listening to them, Senator Alvarado and Representative Ellison, that it is not partisan. This happens to everybody. It happens to whether you're Republican, Democrat, Independent. It doesn't matter where you're from. It can hit us all. So yeah, I haven't heard it either about being the abuse on tip lines right as of now.
Thank you so much. Well, and I know we're at the top of the hour, so I'm going to ask one more question to all of you, and just really, if you could highlight potentially what are policy barriers that you think around mental health emergency response you are experiencing at your level, or that you are really going to be focused on as we start to think about summer committees, fall committees, and then heading into January next year. Assemblywoman Murphy, we'll start with you.
Okay. So you know what? I think we touched a lot on the barriers. One is our workforce, EMTs. We have seen over the last few years a decline in EMT folks who want to be part of that emergency medical technicians for a lot of reasons. One of them is because of the fear of being, if something happens, then they could be sued and things of that nature. Which we did do a bill to address that to some extent, but we're still seeing a great shortage in those. And those first responders are huge when it comes to being able to respond, regardless of what our policy is. We don't have the emergency responders to do it, to be able to respond, not only our EMTs, but our doctors, like Senator Alvarado said, our doctors or technicians, all of that. So I think our workforce at this point is at a crisis, not only in our healthcare, but our EMTs, and also making sure that those folks have the right resources that they need to continue. And a lot of it comes down to money. So where are we when it comes to our resources as far as funding is concerned? So many times we are prevented from putting in certain allocations of money because we just don't have it for whatever reason. So I think those are two huge barriers that I see moving forward that we're going to have to try to get over.
Thank you. And Senator Alvarado, how about you? Anything else to add?
Like I've mentioned before, I think it's really comes down to workforce. I think Representative Lyson says something that's important is GME funding for residency positions. During the pandemic, we had certain locations in the western part of our state that got unfunded basically and stop those because we were worried about funds with the pandemic coming up. Now that we're coming back out of that, it's having to reallocate those funds in the right place. And then I've always tried to encourage a lot of our insurance companies, a lot of MCOs, people that we work with. They talk about funding medical school. I say, medical school is one thing. We need residency positions. They're more expensive. And if I'm a case in point, someone who grew up in California, went to med school there, came to Kentucky, did my residency, and here I am. And still practicing. So it's one of those things that residency spots are probably very important, but it's just developing, really the infrastructure that everything in healthcare comes down to the people that take care of you. And we have to have those folks. Housing transitions, like I mentioned, those are the most difficult things that we struggle with. We'll probably hear some updates. We're going to want to hear how this pilot program, once it rolls out, to see what we can do to help keep people out of our prison systems and just to destigmatize this, to let the liability that was mentioned is a big issue for providers, but it's also for a lot of employers who are willing to give a lot of these folks an opportunity. And if they know there's something in their background, they're not willing for those fears to try to destigmatize a lot of this. And really that's the biggest thing. And a lot of it does come down to funding. So those are all the big issues that I'd say hit us here in Kentucky.
Thank you. And Representative, we'll turn it to you for the last word here.
Very similar issues. I'm going to try to tie together both comments in terms of workforce and funding. As we did a deep dive in Utah, we found that Medicaid reimbursement rates for behavioral health services were in the tank. And we go to try to see how many providers are accepting Medicaid patients in the behavioral substance use disorder space, and it was bleak. And so we did a 20-year analysis and found that Medicaid funding at the state level had lagged significantly behind physical health funding for our Medicaid ACOs. So a bill I ran last session required that we fund behavioral health caseload growth and inflationary growth for Medicaid behavioral health services at the same rate we do physical health funding. And that's critical because people aren't going to go into the profession or accept, some of these patients if they can take cash only patients, as Representative Alvarado or Senator Alvarado mentioned. And so getting a little bit more into the weeds and looking at the reimbursement rates and so forth, I think is critical to address the access and the workforce issues.
Thank you. Well, I just want to say thank you all so much for joining us, to all of our representatives. I know that it's a busy time for you. Either you're in session or it's just ending. Thank you to my colleague Charlie for helping provide excellent context and research around some of these topic areas. And to all of our federal partners that joined us, we really appreciate it. And hopefully we will all see you again in the future for additional conversation. Thank you.
Thank you.